Okay, good evening, everybody. This is Dr. Khalid Anwar. I'm a consultant in physical medicine and rehabilitation at Amana Healthcare in Abu Dhabi. A very warm welcome to everybody, especially to the speakers. Good evening, Dr. Vasti. Dr. Vasti is going to co-chair the session.
Thank you. Thank you.
So this is the 40th MENA Stroke Organization Education Academy Cerebrovascular Grand Round and fourth webinar of the year. This webinar series has successfully brought together a global community of more than 7,500 participants last year. The success can be attributed to our esteemed lineup of 30 speakers, including local and international renowned professors and consultants. As you know, stroke is one of the leading causes of disability and mortality and requires a multidisciplinary approach to manage it both in acute care and rehabilitation. MENA Stroke Organization is playing an important role in educating and spreading awareness to raise standards of stroke care. So in the webinar today, we are going to explore the intricate landscape of cerebrovascular medicine with Dr. Mariam Saida and Dr. Stephen Zieler. This will be followed by presentations of case studies by Zara Ibrahim and Dr. Stephen Zieler. I'm very excited to hear their talks and to participate in the discussion that will follow. So now I will hand over to Dr. Vasti to start the proceedings of the webinar. Dr. Vasti.
Thank you very much. Can we have the agenda up, please? So we are going to start with the case study 1 that will be presented by Ms. Zahra Ibrahim. And let me just, I have a pleasure of introducing her. She's an enthusiastic speech and language therapist who utilize her ability to help the patients and clients to the fullest. She's pursuing a master's degree in speech and language pathology and currently enrolled in a one-year training program with professional certificate of hearing and rehabilitation, PCHR. So can I ask Ms. Ibrahim to present your case?
So I'll be presenting a case today regarding aphasia. So the topic is Aphasia Unveiled, the Journey of Rehabilitation. So if I talk about the basic information, which are the demographics. So the name is N.A. The date of birth, she was born 79 years old when she came to us for rehabilitation. The gender is female. The primary language is Punjabi, and the other languages which used to speak was Urdu and English. The year of stroke was 2019, and the date of emergence was 10th of June 2019. So the referral, she was self-referred, and the frequency of treatment was 45-minute or 1-hour session once a week for 9 to 10 months consistently. And the therapy status, now she has been discharged. So if I talk about the background information, so the onset of its symptoms were shown on 26th of June 2019. So the symptoms at onset were slurred speech, the right-sided weakness, and on finding, she had left MCA, the middle cerebral artery territory infarct, and HbA1c was raised. If I talk about the associated diagnosis or the reason for admission was hypertension, or it was the DM, right? If I talk about the current neurological examinations, so she was awake, she was alert, and yeah, DM is diabetes mellitus, right? So current neurological exam, so it's she was awake, she was alert, oriented, and she was also able to follow the commands. So it was expressive aphasia when she came to when she was seen or when she was hospitalized, yeah, for all these while seeing all the characteristic features, clinical symptoms. So she was expressive aphasia was being diagnosed in the beginning. If I talk about the neurological and medical investigations, so MR head and MR angiography, so impression was left MCA territory infarct without significant mass effect on midline shift. Moreover, occlude left ICA with significantly attenuated left MCA. There is the middle cerebral artery. Internal cerebral artery, yes. So instruction on discharge was when we come to dietary. So it was soft diet, low salt, low fat, and low fat as advised by dietitian. Take all medications on time as prescribed, and follow up in OPD after 3 weeks. When we talk about the regular blood pressure monitoring, so she was not supposed to take that medicine of blood pressure when it's below 135, 185. Okay, so if I talk about the aphasia assessment, so standardized and non-standardized, both assessments were conducted when she visited SLT clinic, speech and language therapy clinic. So standardized, we did VAB, Western Aphasia Battery, and on non-standardized test, we did checklist and informal language assessments. So if I talk about the signs and symptoms, so she had telegraphic speech, like she was speaking in 2 to 3 word utterances, phrases without using, just using the content words, without using, right, what I can say, yeah. So basically, the other functional words, right? Difficulty initiating speech, it was agrammatism, the sentence structure was compromised, she had effortful speech, moreover, she has impaired repetition, perseveration, intact comprehension, and frustration and emotional distress has also been seen, and difficulty in writing as well. So perseveration, you can call it repetition, yeah, ongoing repetition. So when all these things were seen, so she was basically, so it was characterized as she has Broca's aphasia. And she also visited us in the spontaneous stage of recovery, which is 3 months, 3 to 6 months under the window. So the long-term goals were facilitate functional communication and increase speech fluency and intelligibility. So the main purpose, I would say, it was she could able to convey a message across in a social setting. The main goal was to we can form it basically work on her functional communication. We could able to increase speech fluency and intelligibility. We also to improve conversational turn taking. We know the pragmatics, the topic initiation, turn taking, and boost confidence and independence. So that was the primary goal, which can categorize under the long-term goals. If I talk about the short-term goals, yeah. So formulate and verbalize basic phrases and sentences related to daily activities and personal experiences. Practice singing or chanting some simple phrases with exaggerated intonation, patterns to enhance speech fluency and rhythm. So it was more of MIT, which is the melodic intonation therapy. We can, other short-term goal was to engage in repeated practice of scripted phrases and sentences to promote automatic retrieval of language structures, to learn to provide cues and prompts to support accurate speech production, gradually fading support as proficiency increases. So using basic AAC, which is augmentative alternative communication, techniques and devices to express basic needs and preferences during therapy sessions. So the role play in common social scenarios, focusing on initiating conversation, asking questions, and maintaining topic coherence. Practice monitoring and own speech output for errors and implementing self-correction strategies. Yes. Yeah. So the techniques and strategies which were implied during this therapeutic session, during the therapy, was MIT, which is the melodic intonation therapy, which it was errorless teaching, articulation practice, script training, AAC, augmentative and alternative communication, phrase and sentence building, and conversational role play, as I've mentioned before as well. If I talk about the session design, so the session design was across the table sitting. It was an individual therapy, and it was also cyclical approach. And easy, hard, easy, like we used to do some easy task followed by a hard task, then easy, then hard. So a sandwich approach, you could say, and consistent modeling. If I present you this writing, it's basically Urdu writing, this script, and it's basically the sample of writing which I want to show. Like if you can see, I talked about the self-monitoring skills, right? So one, she used to write the sentences, and I would also talk about the generalization as well. Like she used to get home plans, and she used to work with her daughter. She used to sit down, she used to write things, she used to make sentences, she used to write stories, and she used to, even when she used to come to her sessions, she used to bring that piece of paper and to the clinic, and she used to show it to the clinician, and and she would able to rectify the mistakes which she has already done, and she used to self monitor, like you can see like this, like she has cut many things, and she rewrote the sentences, right, like this, so you can able to see all these things, right? So she was able to rewrite and able to identify her own mistakes and to rectify them. If I talk about calculation sample, as I discussed earlier, that she was facing difficulty in even calculation as well. So, like you can see here, sorry, like she was facing difficulty in this one, and she was able to then correct it herself, but she was able to calculate simple calculations, and furthermore after a few sessions she was able to do other verbal calculation as well. So it was something she progressed a lot. So this is the basic one which I want to show, that regarding the self monitoring, and we how we started upon with the calculation sample calculation as well. If I talk about the sample of data collection sheet, like this was basically the sample, the data collection sheet. So it's like conversation, visual perception, completion of sentences, recalling, and you can see that how correctly she was, the sample. We have certain different trials on imitation, on spontaneously, like the correct ones are spontaneous. The dots shows symbolizes that she needed, that we provided assistance to her. So yeah. If I talk about planning of an activity, so we used to plan each and everything, that how many activities we will plan, how many activities we'll be performing in the session, and how to go about the process. And after some time, we started our table topic session. Like we used to give her a topic, and she used to speak, and she has to speak about it for almost 1 to 2 minutes. So 1 minute used to be the minimum time she used to, she used to speak for that respective topic. And I would say like she progressed a lot. There was a time when she started speaking for even 2.5 minutes, which is the maximum time given to her. So yeah, so it was she progressed a lot. If I talk about prognosis, so it was about the client's motivation. It was extrinsic motivation, it was intrinsic as well. She was totally motivated. The family's concern takes a very important, role as well. Like the family was really concerned. The daughter, the other, her son, everyone was in the loop. What's happening in the session? They used to observe. They used to sit inside the session as well. They were accompanied by her daughter in every session. She was a quick learner, and there was consistent carryover at home. Yeah. So if I talk about the effect of therapy, so if I talk about pre-therapy and post-therapy status. So when she came to us, as you can see, limited expressive language, difficulty forming sentences and finding words. Now it's improved expressive language, able to form sentences more fluently and retrieve words with greater ease. Was having difficulty communicating needs and thoughts effectively, frustration during conversation because she was unable to convey her thoughts and message to other people. It was present, like if I give you an example, if the cup is presented to her, she knew what is it. She can, but she was not able to find the right word or to say it. Like there was a right word finding difficulty. She was anomic that time. enhanced ability to express needs and thoughts, reduced frustration during interactions, limited engagement in social interactions due to communication barriers, increased engagement in social interactions, improved ability to participate in conversations. If I talk about the confidence level, it was low before, and now it has been heightened confidence in communication abilities, willingness to engage in social situations. Reduced quality of life due to communication challenges, impacting relationships and daily activities. Now it has been improved quality of life due to enhanced communication skills, better relationships, and increased participation in activities. Yeah. So yeah. So when she was discharged, I mentioned earlier she took therapies for almost 9 months for consistently, but it was 2021 or 2022. Yes, she was coming on off, and like once a month, or you can say she was coming after every 6 months, just for just to discuss. And because she has improved, the only problem she still has, which is not in that much, in a bigger frame, if I call it, like, it's just anomia, a little, in a very, sometimes she faces difficulty in finding words, but eventually she overcome that phase as well. Or so yeah, so thank you very much. So this was my case which I presented to you all. Yeah.
Wonderful physician, clinician, speaker from Johns Hopkins, who I have a pleasure of knowing personally. He is a neurologist, interventional neurologist, and his interests are acute stroke management, stroke recovery, and enhanced stroke care. He graduated from Colorado in, I'll tell you, he doesn't say when he graduated, actually. Degrees from, he got medical and Doctor of Philosophy degree from University of Colorado. He completed a 1-year internal medicine internship at the University of Colorado prior to coming to Johns Hopkins for his residency training. Following his residency, Dr. Stephen then completed a 1-year fellowship in vascular neurology, also at Johns Hopkins. Dr. Stephen now serves as the Director of Vascular Neurology Fellowship at Johns Hopkins, as well as the Director of Clinical Informatics and Technology for Johns Hopkins Neurology. So it's a great pleasure to ask. He's going to do a case presentation for us in the next 10 minutes. So Stephen, without further, please go ahead.
Fabulous. Good afternoon, everybody, or good evening, as the case may be. I am 8 hours behind you all. It's a pleasure to be here. I'm going to give you a case, and I'm also going to give you a talk after that. You just let me know when I can share my screen here. How's that look?
Looks good.
All right. So we're going to talk about small strokes, big problems, and new pathways. And I am shamelessly using this case as an example of some of the things that we think about at Johns Hopkins, not only in terms of diagnostics, but in terms of novel therapeutic interventions. And as I said, we're going to review a case. We're going to look at some unused pathways for recovery and some technology that we use. We're going to talk about Mr. M, who was then a relatively young 42-year-old man with a history of hypertension and high cholesterol, who presented with slurred speech and left-sided facial droop, as well as left-sided arm weakness. And they started at 6 p.m. and in classic Baltimore, Maryland fashion, rather than coming immediately to the emergency department, he decided he would take a nap. And when he woke up 2 hours later, he still had symptoms. And so again, instead of coming to the emergency department, he took a nap. He went to bed, and he finally came to the emergency department 12 hours later. And we learned indeed that he had these history of hypertension and high cholesterol. We learned he was not compliant with his medications. He had a strong family history of hypertension, and really no other significant past medical history. And when we examined him in the emergency department, he had a significantly elevated blood pressure, 207 over 120, and an NIH stroke scale of 7, dominated by this left-sided weakness, such that his left arm was fairly weak, as you can see there. When we obtained an MRI scan about 48 hours post onset of symptoms, you see the distribution of findings there. And indeed, he had a right subcortical capsular/thalamic capsular infarction. And you see not only the corresponding flare change acutely, but we additionally saw other flare changes involving a bit of the external capsule and at least a couple of SWI changes, some microhemorrhages. And so in light of this exam and in light of this MRI, we looked at his blood vessels, and I show you just an example of the extracranial internal carotid arteries right at the bifurcation. And they were surgically unremarkable. He did have a few areas of stenoses that looked very atherosclerotic intracranial. Again, nothing that appeared surgically relevant. And his laboratory values were this. I draw your attention to an LDL of 274, and the rest of his workup was fairly unremarkable. And although we do not do this routinely, because of his young age and what appeared to be some prior strokes, as I showed you, we did check hypercoagulable panel. And one of my colleagues was particularly concerned about the possibility of a small vessel heritable vasculopathy, such as CADASIL. And for those that don't know, that stands for cerebral autosomal dominant arteriopathy with subcortical ischemic leukoencephalopathy. It's an autosomal dominant mutation in the Notch3 gene. And that was negative. And one of the reasons that came up again was because we saw some of this damage in the external capsule. But I'll point out that if we looked at the anterior temporal lobes, we did not see any signal change there, which is a classic location for CADASIL. So although I thought that was reasonable to check, I'm not surprised it was negative. During his admission, we had some significant problems dealing with his very elevated blood pressures. They were difficult to control. You see these numbers here, and we up-titrated a number of medicines and gained moderate to good control. But this took days. And this is one of the things that allowed us to intervene on his significant left-sided weakness. That is to say, as we were working him up, he spent days with us, not only because of this diagnostic workup, but because we had to control his blood pressure. And so we took advantage of that time to provide some additional therapy for him, which I'm going to show you. Now, before I show you that therapy, I will share with you that we actually found what we think is the diagnosis in this gentleman. A 24-hour urine screen showed that he had significantly elevated both meta and normetanephrines in his urine. These are quite elevated, and a scan showed that indeed he had a pheochromocytoma. And our hypothesis is that this pheochromocytoma led to significant elevations, even at a young age, of his blood pressure, and therefore the difficult to control blood pressure. And we are hopeful that once we get that under better control and treatment of his tumor, that is easier. As he sat there and we figured this out, we were able to introduce him to one piece of technology that we refer to as NONO. This is NONO the axolotl, and this is a video game system built specifically for use in patients like this that has a very unique control system in which patients are encouraged to use this so that they can engage in training tasks while at the same time being motivated to be entertained, because this is a very fun video game system. And I'll show you an example of what this looks like here.
The white pearlstone is used with
The patients are given these unique controllers and are able to spin the dials to control the character. And the idea is that the paretic hand is given the black twirl stone and the non-paretic hand is given the white twirl stone, and they are forced to use the dexterity of their fingers and hands to control the character. And in this particular study, we deployed No-No, the axolotl, with our twirl stones at night. In other words, at 6 p.m., when most of the studies, most of the interventions, and otherwise normal therapy would stop, our patient received this specifically designed hand therapy to begin at about 6 p.m. And he was allowed to play and encouraged to play, and the nurses would encourage him to play, such that rather than sitting there doing nothing, he could do something. And I show with you an example of what it looked like as he was attempting to play with some of these games. And he had a lot of fun using this system. Now, when it came time for him to leave the hospital and go home, we have a funded study from Harman Samsung in which patients are granted a box of smartly designed tech connected to a 5G enabled pad such that they are able to track their blood pressure, their steps, their heart rate, their pulse. This is a modular system. And together with my colleagues, Vince Rogalski and Mona Behuth, we can track patients like Mr. M so that we can watch their blood pressure even after they've left the hospital and keep it under control. In other words, the goal is to provide good risk factor reduction and take advantage of the time that we have so that we can provide maximal benefit on the therapy. And with that, I'll acknowledge the people involved in this case listed here, and I'll call your attention especially to a few people. David Gomez, who designed the No-No system, Vince Rogalski, who is our coordinator, who enrolls and works with all of these patients, and Sandra DeLuzio and Kelly Jordan, who are integral in monitoring and working with these patients from a therapy standpoint, and finally Navangi Patel, who is overseeing this nighttime study. And so with that, I will stop and just wet your whistles with the idea that this is the type of thing that we're developing at Johns Hopkins to take advantage of these times and types of patients. Thank you.
Thank you very much, Stephen. That was interesting. And obviously you have just touched the interventions rather than the effects of interventions, which is, I can see because of the constraints of time that we have. I think you'll elaborate a bit more on it in your talk later on. Thank you very much.
I will. This was
my
my amuse-bouche, my appetizer.
That's right. Thank you very much. So, Dr. Khalid, do you want to introduce Dr. Mariam Saeed's talk, or shall I go ahead?
Yeah, thank you, Sabahat. I will introduce Dr. Mariam Saeeda. It is my pleasure to introduce Dr. Mariam. Dr. Mariam Saeeda is a medical speech language pathologist with over 15 years of experience. Dr. Saeeda is certified with the American Speech Language Hearing Association and Speech Language and Audiology Canada. Dr. Saeeda completed her medical training from Daw Medical College, Karachi, Pakistan, and her Masters of Science in Speech Language Pathology from Northeastern University, Boston. Prior to working at American Hospital, she was working at the Al Khan University, Karachi, as a consultant speech pathologist. Furthermore, Dr. Saeeda is a founding member of Pakistan's first 4-year degree program in speech language pathology, Ziauddin College of Speech Language and Hearing Sciences, where she served as an assistant professor. She has a special interest in voice and swallowing disorders. She has taught various courses and conducted workshops on voice and dysphagia management, and has been a keynote speaker at national and international conferences. Today, she's going to talk about approach to aphasia. Welcome, Dr. Mariam Saida. Floor is yours.
Hello. Hi.
Please go ahead.
Can I share my screen?
Sure, please do.
Okay. That in aphasia, a post-stroke, many of the cases have all three areas impacted. Now, how common is this post-stroke, the cognitive communication disorders? So looking at the numbers, about 66% of our patients post-stroke have cognition and communication disorders. 18 to 38% have aphasia and/or dysarthria. And the things impacting our rehab process would be mood and sleep. And 17% have a major depression disorder. 33% have some sort of depression. And about 38% have insomnia, sleep disorders post-stroke. And both of these things greatly impact our the cognitive and communication rehab process. So now coming to assessment. So some things to consider would be, are we in acute care? Are we in a rehab setting? Or are we in an outpatient setting? This would guide us to how to evaluate. How much time do we have to evaluate? And for example, in an acute care setting where we might see a patient only for a couple of days, maybe a comprehensive evaluation might not be possible, or even something that would help us much. But what won't change across settings would be that something that we would always want to know the abilities, the cognitive communication abilities prior to the stroke. We would always counsel the patients and caregivers throughout the process. And always the goals of evaluation and treatment would be that we have a treatment plan with the patient's preference. And the takeaway would be that we have consistent and continued education regarding the new you, the new person the patient with aphasia is. So for evaluation, there are a number of standardized testings. Once again, are these linguistically, culturally, and logistically appropriate at that time? We would have to consider that. So many times in acute care, we are not using these when post-stroke, right? Like the first 2-3 days, or even while the patient is admitted. So once the patient is medically stable and they're back to their baseline, there's a new you. We need to let them know, we need to counsel them. And many times they do not realize what a stroke actually means. They might see it like another hospital admission, but they don't realize, and it's our job to introduce that this might be a new you we're talking about. And they might be back to their baseline, but the new baseline will be very different. And so the education for the patient and the caregivers is very critical. What also we need to know is, where are they going from here? Are they going back home? Are they going to an assisted living facility? Are they going back to a rehab center? What's the family support looking like? What's their situation right now? Are they retired? Are they working? Or what's their role in their family? Are they their primary caregiver for their family members? All of this would be taken into consideration for the whole process, from evaluation to treatment. So looking at back to work, is this a real goal, and how real is it? So there was a study done in 2011 where 288 people with mild stroke returned to work, and 46% of them reported that working became slower. 42% reported not being able to do their job well. 31% reported not as organized and needed external cues. And about 52% reported not being able to concentrate as before stroke. There are a lot of cognitive complaints they have cognitive issues alongside their aphasia and dysarthria. mental fatigue, mental slowness, slowed processing. They lose their train of thought. They have a hard time, difficulty ignoring distractions. They might miss details. They can only deal with one thing at a time. It's really hard to see the bigger picture for them. So going back to work, are we, or is the patient, or is the family setting them up for failure because there's a lot going on? So we need to remember that when we look into goals of going back to work. So we need to assist with goals of care that are reasonable and achievable. That brings us to goal setting. So who's in the driving seat? We have clinician controlled care and patient-centered care. So in clinician-controlled care, the clinician assesses, interprets, does the assessments, interprets the results, and sets the goals and selects therapy. But when it comes to patient-centered care, it's the patient and the clinician jointly, they determine the priorities, and the priorities are the primary focus of the assessment. So we assess in a way that these are the priorities and will we be able to get there? And the patient and clinician set goals collaboratively, and the treatment is selected according to the patient's priorities and goals. So the patient's perspective and the SLP's perspective on goal planning, intervention planning might be different. So the patient is coming to the table wishing to reclaim what was lost and pursue his life goals. They want to be involved in decision making, but they also have limited experience with the rehabilitation and recovery process. So they defer to the SLP as the expert. The SLP, on the other hand, has expertise in speech and language, and they use evidence-based practice, and they're more aware of reality and the prognosis. So there is a discrepancy between the perspectives. Thus, the barriers to keep in mind would be that the patient and SLP may have different outcome expectations. The patient and their families also may have different outcome expectations. We've seen that as well. The families might not understand, but the patient might understand their limitations. So there's also a discrepancy there. And the patient and the SLP may have different knowledge about intervention. And the communication disorder itself at times interferes with developing intervention goals and understanding goal purpose and rationale. So we need to keep in consideration of all of these things when we make our goals. So now coming to how to approach treatment. So treatment selection depends on two variables, the patient variable and goals of treatment. So patient variable would be the type and severity of aphasia and the coexisting impairments, cognitive, or they may be psychological, physical impairments as well. And the goals of treatment, we can focus on reducing the impairment, or we can also focus on improving function and participation in life. This brings us to the WHO International Classification of Function, where we see that if we look at the impairment, activities, and participation, in the impairment model where we work on impairment, the goal is that we will work on the specific impairments, and we hope that the generalization will happen in daily living situations. When we focus on the activities and participation, then our goal is that we're hoping to improve the communication in the normal environment. And we're hoping that, for example, if I'm working on partner training for improved conversation, I'm hoping that the word finding abilities will improve as well. So I'm not targeting on the word finding, but I'm improving I am focusing on improving participation in daily conversations. So the goal would be activities and participation and not the impairment itself. The purpose of aphasia intervention is to improve communicative participation, because communication is the exchange of thoughts, ideas, feelings, or information among people. And communicative participation is communication in real life. And the goal is to reduce social isolation and its health consequences. So for example, if a goal for the patient is that I want to text messages to friends and family, when I'm looking at the impairment-based goals, treatment strategies, I would starting to work on spellings. I would work on spelling short text messages to dictation. But if we're looking at the participation model based goals, I would show the person with aphasia an aphasia-friendly texting messaging app such as Tapgram that allows the patient with aphasia to send pre-programmed messages. This brings them back into the social circle. They're able to communicate with their family. And it's without a keyboard. It's without words. So it does not include their limitations. And they're able to chat and share feelings, and also it can be linked to Facebook. So they're back on social media as well. So for example, these would be the goals we would work on. Rather than the impairment, we'd work on telling our healthcare providers about our needs, understanding therapy instructions, scheduling our appointments, learning new information. Maybe a mother might be working back, engaging in her children's schools activities, participating in financial decision making. So these would be the goals that we would work on. So the question comes in, should we not work on improving the impairment as well? So the considerations that we need to look into is that it is said that when you're working in the acute stage, then impairment focus was assumed to be the most effective in the early weeks. But there are studies that say that, for example, conversation intervention, the results were similar to an impairment-focused treatment. Also, some things to look into is treatment time. For example, in the acute care, many times we only see the patient for a few sessions. And in that session, looking into word finding difficulties might not give us much gain, and that would decrease the patient's motivation and will not be functional. At that time, what he needs are his basic needs to communicate about his health, about his condition, about what's happening at discharge. Those would be the things we would work on for his communication, and that would also give him motivation and have him be in his plan of care. And if we only focus on impairment-based therapy, sometimes research has shown that might not generalize unless and until you're targeting generalization separately as a structured task. So it might show there might be a slow progress towards any functional goal. So we need to embed an impairment-focused target within a treatment that is focused on the activities and life participation. So our goal would be participation, and in that we would embed an impairment-based task. So impairment-based task would look like something on the left, where the patient has to look into any word that would be associated with fabric. But when we look into activities and participation, we could use an AAC device, and we would be able to communicate many more needs and wants and be involved in our daily situations in different environments. Many of our patients, it's hard to explain to them that they are it's very hard for them to move from the speech modality to communication modality. They would want, families and patients are very, really, it's hard for them to understand that, there are other ways to communicate, and communicating 100 needs versus speaking 10 words are much more functional. And that's where we come in, where we have to counsel, and we need to have them be okay with using different forms of communication, just not the normal form that they used to be used to. So treatment considerations that we need to look into, I'll end with this, is that if we're inpatient or we're outpatient, the aphasia, the presentation that we just had, the patient had 9 months of therapy. That we would not have in an inpatient. Inpatient, we have limited time. Now we have the impact of DRGs, and we hardly see patients inpatient, and the insurance and the would not cover that long. And then there's also changing status of the stroke. The stroke it might evolve within the acute stage. So at that time, we have really short times, and we need to use that wisely. Our goals have to be very functional goals, communication with care partners, communicating needs and wants with the patients and the team members. As an outpatient, we can have more comprehensive assessments and treatment programs. As an outpatient, if we have mild aphasia, we can work towards, if they are able to go back to work, goals. When it's moderate to severe, our goals have to be towards improving social engagement and reducing isolation. Another thing that we've seen here is that in considering if they are expats, most of the time we have very limited time with them. So that I would say is empower. We need to spend time because of the short stay, because insurance dries up really fast. And most of the time, unfortunately, there's a loss of job and they have to move back to the home country, and their financial considerations as well coming in. So most of the time, our goal is to empower them with much knowledge, with as much moving ahead, how their life will look like and how to get care for themselves, and how to equip them with any communicative devices so they can communicate their needs and wants and their emotions moving forward. Here in the UAE, what I've seen is that if we have nationals there, if it's not an expat, they have more access to healthcare systems. So we have the ability to have longer therapy. We see patients for 9 months, 6 months, and they have an amazing family support here. So the children are able to take off time for 6 weeks, a month, and be with their parents, with the stroke survivor. And that gives us a really good place where logistical and financial restraints are not there, and we're able to give them optimal treatment. So that's where we want to have so our goals of treatment and the way we work changes there. So that brings my talk to an end.
Thank you very much, Dr. Mariam. Excellent presentation. I know the time is short. Your subject was very vast, and there are a lot we can discuss. What I would suggest is that we will open the floor for questions at the end of the next presentation. I can see there are a few questions already, but those questions relate to Dr. Stephen's previous case presentation. So I will take the questions together after the next talk. Can I ask Dr. Vasti to introduce the next talk, please, Dr. Vasti?
Oh, with pleasure.
You already introduced me.
I introduced you, but this talk is a wonderful talk that you're just about to present. I've had the pleasure of sitting through these talks in person in Dallas, and then you remotely presented it for Leon as well. And it's a wonderful talk, and I would recommend people to hold their attention into what Stephen has to say now. So he's going to talk about enriched environment. Can they rehabilitate stroke rehabilitation? It's a very intriguing talk. He will take you in the next 20 minutes or so through a journey which is possibly the journey of the future for stroke rehabilitation. Thank you very much, Stephen.
Thank you. I appreciate the introduction. All right, let's see what I can do here. All right, please confirm you can see my slides.
We can.
Oh, fabulous. All right. Well, once again, good evening to everybody. And I'm honored to be here and speak with you about some recipes for post-stroke recovery and the use of enriched environments. And As a matter of disclosures, I have received sponsored grants from a number of people, Everpharma, MindMaze, and Harman Samsung. I will not be mentioning any unapproved use of medications. I want to walk you through the natural history of stroke recovery. I want to mention why we think enriched environments are important and how Johns Hopkins Neurology is creating external and internal enriched environments. At the outset, I want to define a few buzzwords. I've already used the phrase enriched, and I'll use that synonymously with how some might use enhanced, by which I mean environments designed to enhance sensory, motor, cognitive stimulation by providing equipment, technology, stimulation, open spaces, socialization, anything that increases the desire to want to engage in recovery-based interventions. So to stay laser focused, we're going to be speaking about motor recovery, which I define strictly as improved success at a motor task that at one point was damaged by a stroke. And I want to be very clear, what I'm talking about here is a reduction in impairment. I guess another way to say that would be a restitution of kinematics. I am not talking about compensation. And the reason that I think we are interested in enriched environments is because of our current situation. And I'll ask the audience just to think about this for a moment. What is the efficacy of occupational therapy on post-stroke impairment reduction? That is to say, a true reduction of impairment or a restitution of kinematics. And just take 10 seconds and think to yourselves, in the post-stroke period with our current instantiation of therapy, how much does it actually lead to a reduction of impairment? And the answer is, are you ready? 0%. I think some of you know this answer. I think to some of you that might be surprising. If we actually look at the data, so for example, this is a Cochrane review from French et al., looking at a number of well-done post-stroke therapy trials. And what we see is that the big black diamond crosses the unity line, meaning we are not hurting our patients, but we're not helping them either. There was a recent study from Verbeek et al. In 2014 that showed that both physical and occupational therapy accounted for about 5% of the variance in post-stroke recovery, which is well within statistical noise. My colleagues and I, Kathy Stenier, Catherine Lang, Winston Byblow, we looked at the trials published in those years indicated there. And in those 4 years, all trials of technology and therapy were neutral. There was one trial that was positive, and that was cerebrolysin. I will mention that at the end. These trials took place in a standard environment. Here's a picture of our standard of care room. This is what a room looks like at Johns Hopkins. It's quite typical of standard environments across different hospitals. And I don't know about you, but this immediately brings to mind Julie Bernhardt's data showing that environments like this potentiate patients spending greater than 60% of their time alone, more than 50% of their time in bed, and only about 13% of their time moving. At best, a patient gets about 1 to 3 hours of time with a therapist, and that's not even time on task. Now, despite all of this, right, we know patients get better. Patients still show improved motor kinematics. If we posit the existence of a baseline motor task, such that at time point 0, that task is affected by a stroke, we know from multiple lines of data that patients do get better. But at some later time point, that recovery plateaus despite continued input. Now, that doesn't mean that they can't learn to compensate. In fact, they can probably learn to compensate at any time, but their recovery plateaus. And why did they get better? Well, this has been looked at by a number of scientists and clinicians. I'll mention by name Prabhakaran, Stenier, Byblow, Winters, Kwakle, and it seems that if we have an intact cortical spinal tract, that is the communication pathway out of the motor cortex, the odds of this recovery is high, and it is mediated by endogenous repair mechanisms. And Some people refer to this as spontaneous recovery because it doesn't need any input externally. This is what the brain and the nervous system affects by itself. In other words, patients get better, but they get better despite us. And that recovery is incomplete. So, what if we want to be better? What if we wanted to beat spontaneous recovery? And I'll use a sports metaphor, if you will. Here's what we want. Obviously, after a patient experiences a stroke, we don't want them to get better at just performing one task, like reaching out and grabbing their toothbrush. We want them to get better at every task that they want to accomplish, whether it's baseball, basketball, tennis, cheerleading, football. However, and I'm being hyperbolic here to make a point, what we often train is one or a small number of tasks. And there is no data that there is generalization. Just because we train on one thing doesn't mean that they'll get better on all of the other things, okay? And so what many of us in the field are asking is, can we improve the endogenous repair mechanisms? Can we do something to enhance spontaneous recovery? And indeed, there is some signal in the noise. There are a number of studies that have showed we can do better. And I've picked out 3 here that I think are worth keeping in your mind. If you don't know these studies and you're interested in stroke recovery, you should absolutely look these up. And I'm not going to speak about them in detail, except to say that Nick Ward in the 2019 study showed that complex, non-task-based, intense therapy, about 90 hours, did lead to improvement, reduction in impairment in the upper limb. Janice Daly in 2019 showed that about 300 hours of intense therapy led to improvement. And Alex Dromerick recently in the CPAS study showed that additional therapy, especially during the critical period of about 20 hours, again, shaped complex movements, led to an improvement. In other words, we can break this glass ceiling, right? There was a way to break through spontaneous recovery. What I'll suggest is that if we wanted to improve in spontaneous recovery, I see 2 mechanisms to do that. We could either quilt together thousands of tasks, or we could consider enriched environments. Now, this is oftentimes what's done now, and one of the knocks against taking this approach is that spontaneous recovery happens during a limited time period. We might run out of time before we're able to accomplish all of this. And so one of the things that we've been doing at Johns Hopkins and in other places is asking, can we take advantage of enriched environments? Well, what is that? All right. As a reminder, these are the spaces designed to enhance sensory, motor, and cognitive stimulation. And in the animal world, enriched environment consists of things like what I've shown here, right? They've got friends and toys and mirrors and balls and wheels and all the other things that animals like that can encourage this cognitive and motoric stimulation. And there are just some fabulous studies showing the importance of enriched environments in preclinical models. And there's a real tour de force study from Bernasky and Corbett that showed some of the importance here. Pardon me just a second. And one of the things that they did here was if they took animals with a very large motor cortical stroke and analyzed their motor performance after the critical period, animals without exposure to an enriched environment had a significant effect on their prehension success. That's a measure of motor performance in rodents. However, if these animals were exposed to an enriched environment during the critical period, so either at 5 or 14 days, they got better. And one of the important outcomes of this study was that the improvement generalized. They got better on tasks for which they were never trained. They got better on things to which they were never exposed, even during the critical period of recovery. And so, as we've attempted to translate this over the years from animals to humans, the question is, what does this look like for a human? And there have been some people that have said, well, maybe this is, we start simple, give them some iPads and books and puzzles and interactions and that type of thing. Whatever it is, I think we can agree that it's not this, sitting in bed, watching the Weather Channel alone. And so at Johns Hopkins, we've tried something new. And I'm going to talk about technology and environment. So let me introduce three human beings, Omar Ahmad, John Krakauer, and Mona Behuth, all of whom have played really an integral role in developing these technologies, deploying these technologies, and creating the clinical ideas that have gone into this type of testing. And we asked ourselves when we developed this, what do humans actually do motorically on a daily basis? And there's this wonderful study from Howard et al. In 2009. You can see that here, that shows that humans tend to use their arms in this electron cloud distribution, if you will. And even if you've watched me here while I've been standing on camera, right, I'm kind of gesturing in this kind of space. That is to say, humans spend most of their lives moving in these statistical clouds shown in these red and green bubbles. Second, the team took advantage of the fact that humans love action and love movement, right? In other words, even if it's an illusion of movement, even if it's not actually movement, we still like to watch it. It's one of the reasons why sports viewership is so high. It's one of the reasons why we love Pixar movies, right? And combining these ideas together is what led to the creation of the enriched environment that we use at Johns Hopkins and is now involved in multiple studies. And this technology is referred to as the MindPod, and you can see the results of this in the SMARTS 2 study. And I would like to acknowledge the massive amount of work that went into this. It was published in NNR, came out in 2021. And in this randomized, single-blind proof of concept trial, we tested the idea that high intensity, high dose upper limb therapy focused on movement quality rather than task accomplishment would reduce motor impairment more than usual care. And we tested this main idea by taking two distinct approaches, right? The first was administering high doses of conventional upper limb therapy, right? And the second was this new immersive, enriched environment that centers on a proprietary form of animation designed to promote this playful exploration of high quality, continuous 3D arm movements, right? And so we found that both approaches led to similar changes in the ARAT, shown here, led to similar changes in the Fuglemeyer, similar changes in reaching kinematics, finger strength, finger individuation, and that both approaches were superior to usual care with respect to the ARAT. Now, the first thing that I want to make clear is that there was no difference between our MindPod therapy and the very high dose, time-matched occupational therapy. And that's likely, right? Because our control was too good. Our control was not usual care. Our control was time-matched, complex, high-dose therapy, much like what Janice Daly and or Nick Ward did in their studies. However, if we compare our results to historical controls, we see large changes in the ARAT. You can see that here. That's been published in the SMARTS 2 trial. In other words, we argue that the changes in the ARAT seen in the MindPod and time-matched OT groups are an indication of true improvement in the quality in arm and hand control and not just compensation. And I'll point out that we saw improvement in the hand as well. And this could not be from training because in the MindPod group, there was no hand training given. In other words, we are seeing generalized improvement in this enriched group of patients in the same way that animals saw a generalized improvement in the Biernacki and Corbett world. This is a generalized intervention. This new approach, for example, this use of the mind pod and the fact that it is as good as high doses of quality occupational therapy, I think should be taken as a reason for optimism, right? The equivalence implies that this intervention must possess some active ingredient that could potentially further be optimized. To wit, we are continuing to provide these types of things. And you guys saw an example of that in the case study that I presented, where we are developing technologies to then deploy at different times. And in this particular instance, you saw an example of NONO, the axolotl being deployed at night at a time during which patients otherwise would not get exposure to rehabilitation. I have no data to share with you on NONO. We are excited to share this with you when we have all of this data done. Now, I told you that we were going to talk about two interacting approaches, technology and environment. I showed you some of the technology. Let me show you some of the environment. The MindPod is being deployed on the inpatient side of things. Mona Behuth is playing a large role in helping to modify the environment of the acute stroke world such that we no longer have patients sitting alone in their bed watching the Weather Channel, but can otherwise be exposed to Bandit. What about the outpatient world? This is an exact picture of what my outpatient room looks like. Pretty standard, pretty boring, pretty awful. It makes me sad just looking at it. Because of SKSI and because of some of the vision that the group at Johns Hopkins had, we had the idea is, could we make something that looked better, something that was inviting, something that had an appeal that would want patients to come to it. And indeed, with the help of a number of architects, visionaries, people that understood this idea, a plan was drawn up, some money was given to us from a number of places, and the Sheikh Khalifa Stroke Institute really understood the importance of this idea, and we set to work to build this room in a clinical area. And a lot of people had no idea what we were talking about, and I appreciate the people involved in this work who saw it through to create this inviting area. And even now, as we are having patients come into this, we're told this is your room. This is your room. You get to make use of it the way you want. And they make it like a space that they live in while they're there, such that they are led to this experience room where the doors open and they are exposed to Bandit. And we're going to skip over this, but what I'll show you here is this is my daughter. She had no idea she was going to be forced to do this in front of some people watching this, where the doors open, the lights that make it look like you're underwater are then taken over by the video game and are controlled by the actions of the game. And the participant, my daughter is fine. She's just being a good sport about this. The participant who would have a hemiparesis, for example, then uses their paretic arm to embody the dolphin and control the dolphin in underwater exploration, catching a fish, swimming through either the water or the air as he jumps out, and perform non-task-based exploratory complex motor movements. Before I step off the stage, I will share that we think that there is a role not only for an external enriched environment, but if you will, an internal enriched environment. That is to say, can we enrich not only the room in which the patient is performing these activities, but the brain milieu in which the patient is performing these activities? And we're not going to go into this today. I'm happy to talk more about this in talks later. But we have a number of experiments, both clinical and preclinical, showing that caloric restriction is important, showing that psychedelics are important, and that showing cerebral lysin is important. And if you recall back to the paper that I mentioned at the beginning of this, the Lancet review, the one pharmacological intervention that has been shown to be useful in this early time period, at least, has been cerebral lysin. And we've seen that both in animals and in humans. And so the idea here is, can we actually create an environment, both internal and external, to capitalize on what the brain does so well, which is repair that generalizes, and encourage that to get even better. We say yes. We have some data to support that, both preclinical and clinical. For those interested, you look at the SMARTS 2 paper, and this is the type of vision that we see. And as we move forward, I think there are a tremendous number of people that need to be acknowledged here, from Johns Hopkins and the number and the people involved in beginning this work and seeing this through, the people at a number of universities that were involved in the SMARTS 2 trial, the people of Kata who understood this vision and helped build the Bandit the Dolphin. John Krakauer, Omar Ahmad, Gerard Wimbley, Pramit Roy, Mike Hamilton have played a big role in getting this rolling. Avitecture and Bill Apter and Eris Design, especially Emily Thompson, played a humongous role in actually building the room that I demonstrated to you all. And Holland Construction and Mind Maze, who have built taken Bandit the Dolphin and built the Mind Pod so that we can deploy this in different places. So let me stop there. I'll show you this screen here and say, that's our introduction. That's our vision. And I'm happy to take any questions.
Thank you very much for a wonderful talk. We have all the speakers now. We have some questions. I will ask them start to Khalid, you still there? Shall we start with the questions?
Yeah,
We have
please.
about 10 minutes or so to
sure.
wrap it up.
Yeah,
So
yeah.
this is a question pertaining to your first talk, Stephen. I think it's probably not something that you can tackle here. Doa Magdi, the first question is, can you share more about CADASIL positive cases? I think that's kind of beyond the scope of this evening, but do you want to comment on that?
Dr. Washti, you are correct. That seems beyond the scope of what we're talking about here. CADASIL is, I'll just say 20 seconds. CADASIL is an exemplar of a small vessel heritable vasculopathy, meaning that you have a mutation, and in this case, it's a dominant mutation, but there are examples of recessive mutations and sex-linked mutations that lead to abnormal blood vessel performance, and therefore you are at risk for stroke. And there are some wonderful review papers that you can pull up. I am by no means an expert in this, but because of what I do, I see some patients with that. CADASIL, CADASIL. Just type in small vessel heritable vasculopathy, and you'll find some wonderful reviews.
Lovely. Thank you. Again, from Dr. Doa Magdi. Is Harman Samsung cost effective? If not, are there any alternatives?
So we've had a lovely interaction with Harman, and they've been a wonderful group with whom to interact because they've actually provided the technology to monitor patients outside of the hospital. And we've done it as part of a research study. And we have data that it works. So the very first question in my mind is, does it work and can it make a clinical difference? And the answer is yes. So then, and there are many other studies, not just ours, showing that it works. Okay, I will refer you to some wonderful work out of Colombia and other places where they monitor stroke patients remotely. But your second question is, or the second part of this is it cost effective? And those are things that depend on where you are and the insurance. And in the United States, there are some unique mechanisms whereby you can get insurance coverage to monitor patients in this type of a realm. This is a rapidly changing area. I hesitate to make any definitive statements because even now we are working with CMS and other people to try to change some of the regulations on how we can remotely monitor patients.
Okay. Thank you. I think, can the speakers and Khalid please turn on your cameras for the discussion? This is what they, so that we can see you folks. I think I'll answer the next question and probably as a chair, skip it. There's a question from an anonymous attendee about, sir, how to manage transient ischemic attacks. I think we probably will skip that one. The next one is again, Dr. Magdi has been very attentive and very sort of involved. That is great. That's great. This question is very interesting, actually. Do you think enriched environment is more suitable for youth or elderly, and versus old classic social interaction, which is more approachable? So basically, what she's saying is, do you think that the enriched environment, knowing that the young will have more technological engagement, they probably may benefit from more? I mean, that makes a little bit of sense. And the more social environment that the old are used to, if you have that built around them, they probably will do better with them. So I think it's a difficult question to ask because there isn't a comparative trial here accordingly. But it's a very interesting thing to ask.
Yeah. So first of all, Dr. Magdi, you should come over and work with us. You got all these questions. Come on over. We'll figure this out together. Number one. Number two, one of the biggest questions, or let me rephrase that, one of the biggest pushbacks that we get from naysayers is, oh my God, you're going to be deploying this to 75 and 80-year-olds. They're not going to want to do this, right? They're not going to want to be involved in playing these games. However, we have seen some of the best responses from people over the age of 65 being involved with this. In fact, we have a colleague at Johns Hopkins who is utilizing the MindPod in the normal age. Her name's Michelle Carlson. And she's shown that people aging past 65 use this technology very, very well and engage in this. Now, to answer your specific question, in which age group does it work better, older than 60 or less than 60? We have no idea. But what I can assure you of is that the elderly are using this and using it well and enjoying it.
Thank you. Some people are raising hands. I think it's best if they type their question in the question and answer section.
I appreciate the protocol-driven nature of Dr. Abbas. Wants to know when they're going to get CME. Yes,
that's right.
Keep us on task.
Point. That's why we all set up here. Yeah, Mahmoud Abbas wants to know when will he get his certificate. That's for the organizers to respond to. Are there any more questions from anyone, or shall we, I and Khalid, wrap it up with the final comments? Don't think there are any more. Well, Khalid, you still there? Your window is quite dark.
Can you see me now?
No.
Okay.
Anyway, do you want to wrap it up, or?
Yeah. So, any questions from the other speakers today? Anybody? I have a question for Dr. Mariam about aphasia, because I'm sure those medical professionals who are looking after stroke patients, aphasia is a very frustrating condition for the patients and the families, and we tend to struggle there, especially if somebody has a global aphasia or receptive aphasia. So I appreciate that we didn't have the time to go much into details of aphasia management. But Dr. Mariam, are there any prognostic features in a stroke patient which can inform us about the prognosis? Because prognosis in aphasia patients seems to remain very uncertain.
So what we've seen is younger patients have done better when the stroke, and basically the mild, and also if we've had them in the acute recovery stage, we've done better. If they're able to accept the fact that they're okay with communication through other modalities, we've seen much better recovery, and we've seen better engagement, and we've seen better results. And otherwise, we've had patients who've spent 9 months, 10 months, but they're very much into, just the normal way of communicating, and we haven't seen much progress there. The global aphasias, looking at the types of aphasias, the global aphasias we've seen are harder. They evolve more to the naming issues. Wernicke's is one of the harder ones we've seen prognostically. So.
Okay, thank you.
Okay. So I think it's been a wonderful evening, I would say, here, and probably morning for you where Dr. Zailer is, of exchange of very interesting information. And we now know that stroke rehabilitation is heading towards a little bit different goals. It's not just about trying to have people move and sit or transfer. It's actually becoming more dynamic and getting people involved in what they do. I liked the presentation from Zahra Ibrahim for the case presentation, which was very interesting to show how persistent therapy, focused therapy can deliver good outcome in terms of improving communication and, in fact, some language. And that led us very nicely into the case presentation by Dr. Zailer, who showed us how the new technologies can be deployed, and the nanos that they have evolved, although they don't have data to show yet how effective it is. But certainly it is something that is exciting to see how, and we will watch the space to see what the outcomes are like. That's wonderful. And then we had a very good overview, I would say, of dysphasia/aphasia management by Dr. Mariam Sayeda. For those who are involved in the stroke care, know that speech impairment and communication deficits can be most frustrating both for the patients and their families. And it is a very important area of stroke care. And having a focused approach and a very systematic and targeted approach is important in dealing with. And I particularly liked the notion that the adjustment to changing from impairment management to actually disability management, and having people starting to communicate without having to try and improve the impairment, is quite a practical approach, and I think that is important. And then finally, we had a wonderful presentation on enriched environments and how that can influence stroke recovery. This is very new and a very novel approach. It's not globally utilized, very few centers that are actually doing it. And Johns Hopkins is one of them, and probably one of the leaders on it. They have been using it, I know, because my involvement in Sheikh Khalifa Stroke Institute, that this is progressively becoming more and more interesting, and the outcomes are becoming more encouraging. So we will continue to watch the space as the new environments, the more enriched environments, more virtual reality stuff starts coming to fore, and see how we can channel these interventions at an early stage to get maximum benefit for the patients. So overall, it was a very exciting evening. It was I thoroughly enjoyed it. And I hope the audience, the participants take away a wonderful message that stroke is not a hands up and given up situation. We are becoming more active, especially from the rehabilitation perspective, and we will continue to pursue it. So thank you very much. Thank you very much for the organizers to have organized such a wonderful evening And until next time, thank you and good night.